Hello and welcome to today's webinar, Proper Documentation of E&M Services to Optimize Reimbursement. Today's webinar will define three key components of clinical documentation necessary to assign an E&M code, show the differences between medical decision-making and medical necessity, and CMS versus CPT guidelines for documentation. My name is Amy Johnson, and in just a few moments we'll be joined by our presenter. If you have any questions that you would like to submit for the question and answer at the end of the webinar, click on the icon with the question mark and type in your question at any point throughout the webinar. We'll gather these questions and try to address as many as time permits at the end of the session. If we don't get to your question, we will follow up with an email to you one-on-one. We will be recording this session in the event that you want to go back and review the material, or if you want to share the presentation with a colleague who was unable to attend. I will distribute the recording of this event to all attendees. Leading our discussion today is Greer Contreras, Vice President of Revenue Cycle Management Compliance. Greer oversees T-Systems RevCycle coding, documentation, and regulatory compliance education programs for clients. Now to kick off our presentation, here's Greer.
Thank you, and good morning. Welcome, everybody. I'm glad you could make it. We're going to be talking about evaluation and management services for the ED space. So we're going to talk a little bit about levels of service that we choose for emergency medicine, how we get there, and the documentation that's needed. For the purpose of this webinar, we're going to be focusing on CPT versus CMS guidelines. And when we talk about CMS guidelines, CMS came out with 1995 guidelines and 1997 guidelines. And for the purposes of this webinar, we're going to focus on those 1995 guidelines. Typically, most emergency departments, coding and billing vendors will use the 95 guidelines. They're more applicable to emergency medicine. So to start us off, we want to talk about three key components. And all these three key components are considered key work in order to assign an evaluation and management service. So we have your history, physical exam, and medical decision-making. In order to bill a code out, either a level 1 through a level 5, all three of these areas must be documented. And then we'll get a little bit later into what some of the for these. So you need your history, your physical exam, your medical decision-making, and within your history category, you have your history of your present illness, your review of systems, and then your past medical, family, and social history, physical exam, and then medical decision-making. Medical decision-making really is the determining factor for the level of service, and what medical decision-making is all the work that went into evaluating the patient. So it's your thought process, that's all the physical work as well as your cognitive work. And then CMS also throws in medical necessity. And in order to bill a service to CMS, so to your government payers, medical necessity is considered the overarching criterion for payment. So what that means is medical necessity kind of trumps everything. While it's not specifically mentioned in the CPT guidelines, it is why you do your medical decision-making. So let's move on to and break down some of the requirements. So for your history, your HPI, you'll see there that we have a little table for CMS, and then down at the bottom we're talking, those are CPT guidelines. And you'll see that CPT rules are generally less numerically concrete. They allow for a little bit more clinical latitude based on the medical necessity. They're not giving you absolutes as far as how many elements are needed within the HPI or the ROS, past family social history. So you'll see here, for our level 5 and 4 in the HPI, you need at least 4 elements documented. And what are the elements? We're talking about timing, context, associated signs and symptoms, severity, modifying factors. So when the patient comes in, it's taking that story. That's what your history of present illness is, generated by that chief complaint. And that chief complaint in the CPT world is the nature of the presenting problem. So the patient comes in and they come in with chest pain. So you're taking your history of present illness and asking about this chest pain whatever is clinically relevant is what you want to get in that HPI. You want to be as descriptive as possible. This is going to help, for the providers that are on the phone, this is going to help your billing and coding vendors really figure out what's going on with the patient. It's also going to help support the overall level of service that's ultimately decided upon if you really paint that picture. So you want to use descriptive language, you know, how severe is the chest pain, how long has it lasted. Give it as much detail as possible. You'll see here that for CPT guidelines, they talk about a problem-focused HPI, an expanded problem-focused HPI, detailed and comprehensive. None of those have numerically associated bullets with them, meaning a brief each HPI. It's not telling us that we only need one element, but if you go up to the table and see in your level 1, that would be a problem-focused HPI, and CMS requires at least one element. So this is one of the areas that CPT and CMS differ, and it could be more beneficial because it's, you know, you don't have to quantify the number of HPI elements for your non-government payers, but it gets a little sticky as we move on into the higher levels of service, and I'll talk about that in just a minute. Past family social history and review of systems. Again, you know, you're looking at your higher level of service here, your level 5. For CMS, you'll see that the past family social history requires 2 out of the 3, and your review of systems is at least 10 systems. Now down below, if we flip over to CPT world, a comprehensive review of systems is a review of all additional body systems. CPT also says that you need a complete past family social history. So a complete past family social history is a past, a family, and a social. Whereas if we go up into CMS, you only need 2 of the 3. So CMS, the guidelines for this past family social area are less than the CPT guidelines. And this is really the only area where that occurs. But you have to be aware of it if you're doing your coding and you're coding based strictly on CPT guidelines or documenting based strictly on CPT guidelines, you need to be aware of the differences there. For your review of systems, you can see it in this table here. It's quantified for CMS. It's not as quantified for CPT except when we come to that comprehensive. The other thing with your review of systems is it's important to individually document all of your pertinent systems. This is where CMS also gives you kind of a documentation, lessens the burden of your documentation of review of systems. There are carriers, the 95 guidelines, and then different carriers that will accept the all other systems reviewed and negative statement. And what that means is you've done a comprehensive review of systems. So in the CMS world, that means you've reviewed at least 10 systems. You document your pertinent positives and negatives, and then you can state all other systems reviewed and negative instead of individually documenting every system. So it gives you a little break there on having to go in and document everything individually. The other thing with the past family social history is you need to be specific. CMS states one specific item must be addressed in order to qualify. CPT says that you need a specific item that is directly related to the chief complaint. So what you want to avoid in this circumstances is using language like non-contributory or negative. When we come to audits, that type of language can be problematic. Non-contributory to the chief complaint, so I didn't ask the question, or non-contributory, the answer was non-contributory. It can mean many things. So it's just stronger, better documentation, clearer documentation to stay away from some of that language. You know, stay away from negative, stay away from non-contributory. If the patient comes in, talk about that chest pain patient again. Patient presents with chest pain, family history, no family history of cardiac disease. Again, you want to try to tie it in to why that patient's coming into the emergency department. You know, that you want to let these key components be your guide. Your medical decision making is driving you down, and because the number and the nature of clinical problems you're addressing, as well as the risk to the patient, the complexity of your medical decision-making, that is what should drive the overall history of present illness, meaning the amounts that you're taking in, the physical exam that you're doing. So it all ties together there. Moving on to the physical exam, this is an area where, again, CMS quantifies, and down below, CPT does not give you as many, bullet points there. We need X amount. It's a limited exam of affected body areas or organ systems, where CMS, level 5, you need at least 8, level 4, 5, you can see that through. This is in CPT language. Let's look at our highest level here, our level 5 service. You need a comprehensive exam, which a comprehensive exam is a general multi-system exam or a complete exam of a single organ system. And this is one of the areas that the 97 and 95 guidelines vary in their exam, and the 95 guidelines fit better in the emergency department space. Typically, you're doing for a higher acuity patient, you're doing a general multi-system exam. Now let's talk about the regulatory climate and how this affects your documentation, and we're going to start really getting into the meat and potatoes of your medical decision-making documentation and medical necessity. Right now, we are seeing increased governmental auditing across the board, just nationwide. With CMS and Medicaid, California Medi-Cal, we have RACs and certs, prepayment probes, prepayment medical reviews. We have a couple carriers out there right now that are doing special probe audits of emergency room 99285 visits. And we're starting to see some of that come back, and we're seeing medical necessity denials. That's really frustrating. And what we need to do in this ED space is make sure that the documentation supports the level that's being chosen. Your work, without a doubt, is being documented. As physicians, you're treating your patients, you're documenting what you're doing, but now we've got this other piece in there, which is medical necessity. You've probably all been trained and taught either by your billing and coding vendors or your hospital staff how important it is to document everything you do when it comes to your medical decision making. Now there's this other piece in there of medical necessity, and after all, who's more knowledgeable about the patient's medical needs? It's certainly not your coder or the auditor. It's the clinician that's there with the patient. We're now seeing that maybe we need a little bit more documentation. The medical record serves many masters. It's not just for reimbursement. It's, continuation of care. You've got lots of eyes that are looking at your charting and your documentation. So it needs to be very clear where you were going and why you were doing what you were doing. So, medical necessity versus medical decision-making, you can think of it in a couple of different ways. The medical decision-making is the actual action and what you were doing. The medical necessity is why you needed to do it. So up here on this screen, we've got some Medicare language. CMS states that the service must be reasonable and necessary for the diagnosis and treatment. So the reason I put this slide up here is this is actual CMS language, and so we want to talk a little bit about that and how that fits into the way that you're doing your coding and sending things out. So frequency of service really isn't pertinent in the ED space. It's more the intensity of service or the level of acuity. So is it a level 3 patient versus the level 5 patient? And the burden is on physician documentation to make sure that it's clear within the record what that intensity was, meaning, how sick was the patient? How severe was this patient? Why did you have to do this workup? All of that needs to be included within the record. The next thing they want the documentation to demonstrate is the intensity of the service was appropriate considering the nature of the presenting problem. So what does that mean? It means they're trying to tie in, hey, this workup was needed for this chief complaint. So the patient came in with chest pain, and you decided to do a chest x-ray, EKG, cardiac enzymes. Another clinician might pick up that chart and see, oh, yeah, patient came in with chest pain, 55-year-old male, have family history of cardiac disease, and it should be clear why you decided to order that cardiac workup. again, you need to remember that there might not be a clinical individual that's looking at this chart later on. So you need to document why you're doing what you're doing. So, indication for the testing, why you decided to do that EKG. The number of problems and the physician's work evaluating the problems is clearly demonstrated. So we're going to go back to talking about key component work. So if we go back to the first slide, our key components were our history, physical exam, and medical decision-making. So medical necessity is the driving force behind that medical decision-making. So it was medically necessary to treat and diagnose this patient, so I determined I needed to order this diagnostic workup. And then, you want it to support your conclusions, and how do you do that? Documenting everything that you're thinking. Make sure your cognitive work gets into your documentation. It's really easy to click off that, yes, I ordered an EKG, document your interpretations, document what you're doing. But what we find missing a lot in the documentation, or more often in the documentation, is the why behind it. Tell us why you're doing it. Paint a picture, a very clear picture of the progress of the encounter, helps support that overall level, and really goes a long way in supporting in an audit scenario. So the challenge is quantifying and qualifying your thought processes. So, again, this is how much do I need to document? Is Greer sitting here telling me I need to do paragraphs upon paragraphs of medical decision-making and medical necessity? No, it just needs to be clear. What we want to do here is eliminate any need for inference from an auditor. And to help your coders out, the more you paint the clear picture of the visit, how sick the patient was, why you're doing what you're doing, did things not go the way that you expected them to, and you took a different path. If you think about all of that work that you're doing in your head, doesn't necessarily get into your documentation, yet it's very important that it's there. We have different carriers now that have actually published things on their websites that say if the medical necessity behind the diagnostic test is not clearly stated in the record, then the service will be denied for not medically necessary. So, we're definitely starting to see a lot more about medical necessity out there, and we want to make sure that you're doing the work. Obviously, it's medically necessary, or you wouldn't be doing it. So the next piece is documenting why you're doing that. So documentation of medical necessity. So I just put up here again, what Medicare says. Medicare will not cover services that are not reasonable and necessary for the diagnosis or treatment of illness or injury. So I'm just repeating how important this is. And this is very subjective on either a coder's or an auditor's end. Again, we don't know. The physician and the provider, you're the one that knows what's right to do for the patient. You're the one that's determining what those medical needs are. What you want to make sure is that you put it into your documentation. So make sure you're documenting a clear picture of that patient's clinical condition, the severity of, if a patient comes in with abdominal pain, don't just tell us abdominal pain. Give us some detail of it, the quality of it, the severity of it. Again, painting a clear picture of what this service was all about. You've got billing and coding vendors and auditors that are looking at an electronic medical record or a paper template and determining how sick this patient was. What was the value of all of the work that you did? So that's why it's so important to get that into the record. The reason for the service in enough detail that a reasonable observer could understand. So that's just what I was talking about. Somebody who maybe doesn't have the clinical background but can look at your chart and look at your documentation and really understand, hey, this was a sick patient. It definitely was a high acuity patient. There's a comprehensive history. There's a comprehensive exam. The medical decision making is clearly supported with also medical necessity. The physician indicated why that chest x-ray was needed. Physician indicated why we did the cardiac enzymes. All of that is important. Again, just taking us down the path of what happened during this visit. Talk a little bit about documentation of medical decision making, and this documentation is much easier as far as in comparison to medical necessity. Medical necessity, as physicians and as I'm out talking to physicians, a lot of the kickback that I'll get is, well, of course I'm ordering that EKG. The patient comes in with chest pain. Anybody should know that, put those two things together. And I agree, and it's frustrating. But with that thought in mind that, hey, there are other people looking at this account, at these charts, that might not have that clinical background, the more that you discuss, overall, kind of making a bulletproof chart, it's really hard for anybody to argue that it wasn't medically necessary. Documentation of your medical decision-making, again, explaining your thoughts behind the decisions, documenting your working differential diagnosis, and so this is key. This kind of leads both coders and auditors into what you were thinking about. And that abdominal pain patient that comes in, you might have a laundry list of differentials. All you really need to document is where you're going. In other words, what you're going to be ruling out or what your workup is pertaining to. So your working differentials. Each chief complaint can, again, have a laundry list of differentials, and you don't need to document every one of them, and it really wouldn't be pertinent to document every one of them. You want to document what you're working up. Make sure you document everything that you're doing. This goes towards your medical decision making. If you're reviewing old records, make sure you document that. Summarize it in your record. Ordering, reviewing, interpretation of tests, that goes without saying. Document everything that you do. Even if you're not billing, you're not separately billing for some of these, your CTs, you're probably not billing out for, radiology. Some groups do, some groups don't. Same with EKGs for cardiology. You're still making decisions based on those interpretations or those reviews. So it's important to go ahead and document that. Consultations with other physicians. If you're needing to talk to another physician, make sure that gets into the record. The reason why you needed to do a consult. All the meds that you're giving or prescribing if you're discharging the patient. Throughout the visit, your reevaluations, make sure you document those. Is the patient improving, getting better, getting worse? The path is changing. Your treatment decision is moving in a different direction. Those are important areas to have documented in your chart.
Thanks, Greer. We do have a couple of questions, so I'm going to go ahead and read those off to you, but if any of you guys have any more questions, please feel free to type them in, and we will get to those. First, do you have any examples of conditions that can assist with determining the level of risk?
So that's a great question. So as asking whether there's certain chief complaints that then could go into a different level of risk. That's hard to marry together because, again, your level of risk is determined based on multiple things and not just the chief complaint. You could have a patient that comes in with abdominal pain, but based on your physical exam, you're not too concerned for that acute appendicitis or small bowel obstruction, so you're not ordering, diagnostic testing, or you're not doing, it's moderate abdominal pain. You're not doing as much as far as pain management is concerned. So there's not a direct correlation that's just easy to throw out there. There's some generalized things that come to mind. Some of your respiratory complaints, your shortness of breath that comes in, those are tend to be higher acuity patients, depending on the age of the patient, as well as your abdominal pain and your chest pain. Those can tend to fall into your higher risk type patients. Also, some of the procedures or treatments that you're doing, if they're higher risk procedures or higher risk treatments, so some of the meds that you're giving, those also can increase the level of risk. So it's not just that presenting problem. You want to support all your workup with that presenting problem, but it's the combination of what you're doing throughout the entire visit. that determines that overall risk.
Okay, the next question is, how are providers who are using an EHR typically documenting their thinking for medical necessity and decision-making when they are using templates for HPI, ROS, and PE?
Right, so I think I understand the question is, within your EMR, you have different click boxes, and of course there are multiple different types of EMRs that you can do. Get your 4 and your HPI, you can get that history physical exam down really well, and then when it comes to the medical decision making and the medical necessity, it's a little bit more difficult. That really needs to be a type of free text. And I know all of the EMRs and the physicians that are listening right now are cringing because I'm saying that you need to do some free text when it comes to medical necessity and medical decision making, but it's really important. The other thing is a lot of the EMRs and in your CPOE type systems where you're doing your orders, most of those require an indication for why you're ordering it. So that helps for the medical necessity. You don't have to have duplicate documentation throughout the record. If you've got in your order section that you're ordering the CT to rule out acute appendicitis, you don't then need to go free text it within your EMR. As long as it's somewhere in the record that it can be tied together, that's sufficient for supporting that medical necessity of that service. But I do recommend that when it comes to your higher acuity patients, again, is what we're talking about here. We're not talking about a straightforward patient that comes in, doesn't need a lot of medical decision making. There's not a lot of medical necessity going on behind that. So you don't have to worry about some of your more level 3 type patients. It's your higher acuity patients that you're going to want to add a little bit of free texting in, just your cognitive work there, some of those thought processes.
Okay, with office visits, it's easy to differentiate between new problem, no additional workup versus new problem with additional workup. Any suggestions for the ED?
So for the ED, and what this question is coming from is, that there's kind of that point system when you're coding, and in the ED, every patient is a new patient to the provider. That might be a frequent flyer, but could be a different physician. So typically every patient is a new patient to the provider, and you either break it down with additional workup planned or without additional workup planned. And there's many schools of thought on additional workup planned. Different carriers, most carriers don't have it defined, meaning, what do you consider additional workup planned? Is that anything that happens after the history and exam, after you've done an H&P? All of that is considered additional workup planned, or is it only once the patient's left the ED? So there's different ways to look at that. But as far as determining an established problem versus a new problem in the ED space, really the patients are new patients to the provider. It's not like an office visit. There is no history. The ED physicians aren't primary care. They're not following these patients, so they need to dig in a little bit more. I hope that answered that question.
You referenced the 95-97 CMS guidelines earlier. Where can I find or obtain these guidelines, or is there somewhere online that I can download them?
Yes, they are on CMS's website, and if you go to the CMS website, and I'm sure we can post that or send that link.
Sure, absolutely.
Follow up. So we can provide that for you, and you can download both of them. Again, the 95 guidelines, your CMS says that you can use the 95 or the 97, whichever is most beneficial for the physician. What you can't do is pick a couple of areas in the 97 guidelines and a couple of areas in the 95 guidelines on the same patient. You do have the ability to use 97 or 95, but once you review it, you'll see that the 95 guidelines really do work better in the ED space.
When I send out the email with this recording, I'll also put the website on there of the CMS guidelines.
Great.
Okay, the next question is, if I'm using a scribe, how can I get a scribe to understand this and apply it?
Great question. Hard answer. So I think that, you know, different scribe companies, whether you're training your own scribes or whether a company is coming in and giving you the scribes, one of the most important pieces of training a scribe is training them on these documentation guidelines. You want to go through and give them the basics of documentation, so what the requirements are, and then explain, and, you know, providers have you know, are the most knowledgeable as to why you're doing the workups that you're doing. And so, you know, a scribe is a tape recorder of everything that you're doing within this encounter, and they can be very helpful for you, but they're not clinicians either. So, you know, the burden then, again, is on the provider or whoever is providing you your scribe services to give each scribe a comprehensive training in documentation requirements.
Okay, the next question. If a provider marks only review of systems, all others are negative, without listing any pertinent positives, do they get credit for completing a review of systems?
I would say no to that. You need to, and that would be a rare circumstance, because the other thing that you need to remember, and it kind of goes back to not having repetitive documentation, is just, let's say we're talking about either an EMR or a paper template where there's a section that says review of systems, and there's a box that the provider can check that says, you know, all systems reviewed and negative, and nothing else is checked. So, you know, there's nothing checked in GI or constitutional. It's just that box that's checked. That wouldn't be sufficient, because the pertinence, whatever the patient's coming in for, they have to have at least one pertinent review of systems, because a review of systems, the patient's coming in with a complaint. You go back over and look at your HPI, and that's where your HPI can help you out. You know, there are some providers that do their review of systems within their history of present illness, and that's sufficient. You don't have to do repetitive documentation. So it's a rare occurrence that you won't have at least one pertinent documented. You want to stay away from just, you know, giving credit for a comprehensive review of systems if truly all there is a box checked off, all other systems reviewed and negative, and let's say it was a very, very light HPI that for some reason didn't have a chief complaint. You're going to have trouble coding that anyway, and certainly wouldn't be able to get it to a comprehensive level. So you want to have your pertinence documented.
Critical care time. Is there certain illnesses that we should be marking critical care time regardless, i.e. COPD requiring hour-long treatment?
No. I'm going to say no. Critical care time, you know, that, and I believe we will be having a webinar on critical care. We didn't go into critical care on this one, but I will address this question, is, you know, they're kind of like the question about how do you determine the risk and what type of presenting problem, and is there any crosswalks to that? COPD is a great example of something that absolutely could be critical care, but you wouldn't document critical care for COPD every time. You'd only document critical care if it truly met the criteria. And there's more than just time when it comes to critical care. There's the clinical condition of the patient, as well as the treatment and the urgency of the treatment that goes into critical care, and then that time threshold. So in order to document your critical care time, you have to meet the rest of that criteria. You have to be actually treating that patient, and they need to meet all three criteria.
Okay, I believe we have another question. Is there a minimum number of items one must check in order for a system to count? For example, is saying no headaches good enough for neuro-ROS, or moist mucous membrane for HENT physical exam?
Yes, that is sufficient. Within the 95 guidelines, you don't have to have a certain number of elements or bullets. That's one of the differences between the 95 and the 97. So simply stating, you know, no headaches is adequate for the purposes of using 95 guidelines.
Okay, and in the T system, will the DDX and MDM cover the necessity?
So the differential diagnosis and the MDM section. Differential diagnosis certainly help support the medical necessity of the service, and I'm not sure about the MDM section. I would have to go in, or if you could give me a little bit more to that question, what exactly you're asking there within the TEV system. And I think if you're typing your question, we'll be patient for that. Differentials help support, but they're, that's not all you want.
Okay, and I'm getting a lot of requests for the slides, and when I send out the recording tomorrow, I will also include the slides for you as well, so you can have them to print out or to show others that couldn't make it to the webinar. So we'll give you just a last little second to ask maybe another question, but I think that's all the questions for now. Okay, well, I think that's all the questions for now. Thank you so much for attending today's session. We will be sending that email out to you tomorrow so you can have the slides and a recording.
We'll also send out the link to CMS.
Yes, with the link to